Hello friends, so I'll be talking on this hyponatremia, which is a long overdue topic. So I had covered other electrolytes like calcium, magnesium, phosphorus. So hyponatremia and hypernatremia I would be covering soon. So this topic I would be dividing into 2 to 3 parts. So the first talk which I'm giving now is a overview for all the basic trainees. So it gives you a basic fundamental understanding of hyponatremia. So hyponatremia is defined as any sodium that would be less than 135 millimoles per liter. And in the absence of hyperglycemia, generally hyponatremia suggests there is a hypoosmolar state. There are hyperosmolar and normosmolar, but predominantly most hyponatremia is associated with hypoosmolar state. And during in this state, because there is hypoosmolar, there is increase in the intracellular fluid levels. So there are basically 3 steps that are involved in kidney to excrete water load. So the first step is to secretion of water and electrolytes into the diluting site of the neuron, which is the Ascending-Limb loop of Henle. And there is an active absorption of sodium and chloride from the thick ascending limb, and this absorption happens without water. So this is a normal steps how the kidney eliminates water. So there is water and electrolyte secretion into the diluting site of the nephron, and there is active reabsorption of sodium and chloride from the thick ascending limb without the water, and there is maintenance of dilute urine within the collecting tubules. This dilute urine does not get absorbed unless there is, in the absence of antidiuretic hormone, this does not get absorbed. But when there is more antidiuretic hormone from the collecting duct, this water will get absorbed, and which prevents the excretion of the water, which causes relative hyponatremia. So these are the generally 3 steps that are involved in the water excretion. So there is absence of antidiuretic. So this dilute urine maintains in the collecting tubules and water gets excreted. Any of these gets hampered, hyponatremia sets in. So let's look into each one. As I said, most of the hyponatremia is associated with a low osmolar state. And when there is a low osmolar state, there is, as I said, there is increase in the intracellular fluid content. But the extracellular fluid, there can be 3 possibilities. So the extracellular fluid can be reduced, can be normal, or extracellular fluid can be more. So we look at all the causes of hyponatremia are divided based on this extracellular fluid being normal, reduced, or increased. So in hyponatremia, due to hyposmolar state can occur due to sodium loss or excess water gain. So we look into the causes of hyponatremia with reduced extracellular fluid. So when there is a reduce in extracellular fluid, so there is a relative arterial hypovolemia would be there, and this would be sensed with increase in the thirst mechanism. So when there is a effective circulating volume is reduced, so that is perceived as increased thirst. So when there is an increased thirst, it leads to increased production of vasopressin from the posterior pituitary, and this manifests with and some of the causes of this hyponatremia due to reduced extracellular fluid is vomiting or due to diuretics. So in these situations, the potassium from the cells go out and the sodium gets absorbed from the extracellular fluid and the hyponatremia sets in. So this is a condition where extracellular fluid is reduced due to vomiting or due to the use of diuretics, where relative hypovolemia causes increase in the vasopressin secretion due to the thirst mechanism. So one thing listeners need to bear in mind throughout this narrative of hyponatremia, you would be seeing, I'll be showing this common picture where there is increase in the production of vasopressin. So most causes of hyponatremia is due to increase in the circulating vasopressin or antidiuretic hormone. So as the name suggests, antidiuretic, it prevents diuresis and it conserves water. And that is the basic pathognomonic feature or the cause underlying any hyponatremia. There is increase in the ADH levels within the body. And the causes can be many. So let's look into the causes of hyponatremia. So we looked at the cause due to decreased extracellular fluid. So there are situations where hyponatremia can occur due to increase in the extracellular fluid, where here the increase in the sodium is exceeded by the increase in the water content. And as the name suggests, because there's increase in the extracellular fluid, This typically occurs in all these organ failures. So heart failure, cirrhosis, or nephrotic syndrome, or oliguric phase of acute kidney injury or chronic kidney injury, where kidney loses its ability to excrete the water from the body. So there also hyponatremia can occur due to increase in the extracellular fluid. Even here, the underlying pathophysiology is reduction in the effective circulating volume, which is sensed as increased thirst and leading to increased secretion of vasopressin from the posterior pituitary. So we looked at the causes of hypoosmolar hyponatremia due to reduced extracellular fluid, due to increased extracellular fluid. So the commonest cause of hyponatremia and hypoosmolar hyponatremia is very often due to normal extracellular fluid. And the commonest cause of normal extracellular fluid is SIADH, syndrome of inappropriate antidiuretic hormone. So in SIADH, there is hypoosmolar hyponatremia. The key differentiator is there is euvolemia, there is normovolemia, there is no reduced extracellular fluid or there is no increased extracellular, there is normovolemia. And here urine osmolality will be more than 100 milliosmoles per kg. And there will be normal adrenal function and the thyroid function. So this is one of the important factors that needs to be excluded before you call it as SIADH. There will be normal adrenal function and normal thyroid function. So even here, as I said, throughout the narrative, the commonest underlying pathophysiology is increase in the vasopressin levels or ADH levels. Even here in SIADH, there is non-physiologic release of vasopressin from the posterior pituitary. So some of the causes of SIADH or neuropsychiatric disorder or chronic lung conditions or underlying malignancy would be the common, or sometimes it can be age-related issue also. So there are other causes, as I said, for calling it SIADH, we have to rule out hypothyroidism or cortisol glucocorticoid deficiency, which means to say hypothyroidism and glucocorticoid deficiency also causes hyponatremia, hypoosmolar hyponatremia with normal extracellular fluid. So when there is a glucocorticoid deficiency, so when there is a reduced cortisol production, so this is sensed by the posterior pituitary, which increases the production of corticotropin releasing hormone. Because the posterior pituitary is activated to increase in the production of corticotropin releasing hormone or increase secretion, there is a concomitant increase in the secretion of vasopressin also. And when there is a cortisol deficiency, there is mineralocorticoid deficiency also leading to relative hypovolemia, which again stimulates the thirst and there is increased production of vasopressin. So this is the underlying pathophysiology in glucocorticoid deficiency. How about in hypothyroidism? In hypothyroidism, there is reduction in the cardiac output and reduction in GFR. Both leads to reduction in the effective arterial volume and leads to increased vasopressin production. So at the end of the day, the basic underlying pathophysiology will always be increase in the ADH levels in the body, which leads to hyponatremia. So let's look into pharmacological agents which causes hyponatremia. So again, there are pharmacological agents which stimulate the release of vasopressin from the posterior pituitary, and some of them are the ones which are central acting, like carbazepine and tricyclic antidepressants or anti-neoplastic drugs or antipsychotic drugs, narcotics and nicotine. All these act or sort of have a central action which leads to increase in the production of vasopressin. There are certain agents which potentiate the action of vasopressin. They are chlorpropamide, methylxanthines, and NSAIDs. They tend to enhance the activity of vasopressin. And there are other pharmacological agents like vasopressin analogs like oxytocin and DDLP. All of this can cause hyponatremia. There are other causes like stress, emotional stress, which can lead to increased vasopressin production, or primary polydipsia, where there is excessive consumption of water beyond kidney's ability to concentrate urine, which is more than 12 liters. When there is a urine output exceeding that, kidneys will unable to concentrate the urine. That can lead to hyponatremia and acute hypoxia and hypercapnia. So these are some of the causes which increases the release of vasopressin to the posterior pituitary, leading to hyponatremia. So we have looked at predominantly. So when we say hyponatremia with hypoosmolality, we should always keep in mind that it is divided into reduced extracellular fluid, normal extracellular fluid, which is SIADH, or increased extracellular fluid, which is heart failure, cirrhosis, or nephrotic syndrome. So there are certain causes for hyponatremia with normal osmolality. This typically happens in paraproteinemias like multiple myeloma or hyperlipidemia, and this is called pseudo hyponatremia. Why it is called? So when you look at the plasma, there is an aqueous portion of the plasma which constitutes 93%. And this is the aqueous portion of the plasma is what contains sodium. And the 7% constitute these proteins. All these sediments you see is the proteins. So when there is relative increase in the sediment, so when these proteins increase or the lipids increase, so this water content comes down. So there is a relative sodium deficiency that gets reflected, which is called pseudo. So there is no actual sodium deficiency because the water content comes down. Sodium appears to have come down. This is called pseudo hyponatremia. So this is another pictorial representation where you are seeing this is a normal where sodium content appears more, but here your proteins have increased or lipids have increased and the sodium appears less. So this is a pictorial representation of how pseudo hyponatremia occurs. So then there is the hyponatremia can also occur with hyperosmolality. So this typically happens when there is high glucose levels. So here what happens is because there are increased solutes. So these are the blue things are the solutes which are increased in the extracellular fluid. And there is a higher sort of a osmotic gradient. So the water within the cells get absorbed or transmigrates into the extracellular fluid space, which leads to hyponatremia. And the causes is hyperglycemia because when you have increased sugar in the blood, so there is increased tonicity which attracts the fluid to be which extracts the fluid to come out of the cells, leading to hyponatremia. Hyperglycemia is one, or extraneous molecule like mannitol administration can lead to drawing of the fluid from the cells into the extracellular fluid compartment, leading to hyponatremia. And especially in DKA or hyperosmolar coma, so you would see sodium being low. And this is a typical exam question we ask, what is the correction of the sodium? Because sodium will be reflected as being low, but you have to calculate the true sodium. For every 100 milligram per deciliter increase in glucose, 1.4 millimoles per liter of sodium deficiency is reflected. So this has to be calculated when you have patient coming with very high sugars with a sodium of 120. So you need to factor in for every 100 rise, 1.4 millimoles reduction of sodium is what will be reflected, and that has to be calculated. So let's now jump into the clinical manifestations of hyponatremia. Can be very vague. I'm sure every listener here would have dealt with hyponatremia. You would see the patients come with little altered sensorium, drowsiness, fatigue, headache, confusion, coma. And if it is severe hyponatremia, many a times you would have witnessed patients coming with the seizure episodes. And initially they can have nausea, vomiting, lethargy, malaise. So these are all non-specific symptoms. But the predominant symptoms everyone would have witnessed is altered mental status, confusion, and seizures is something which many of you would have seen coming to ICU. So diagnosis is the interesting part. So we have looked into all the causes. We have to put it all into nutshell to ascertain the diagnosis. For diagnosis of hyponatremia, there are three important aspects that every treating practitioner or a doctor should do. One is to calculate serum osmolality, plasma osmolality, and you have to look at urine osmolality and urine sodium and chloride. So these give you the diagnostic clues as to the underlying etiology that may be causing hyponatremia. So why do we do plasma osmolality? Basically, once you do the osmolality, you either get a normo-osmolar, hypoosmolar, hyperosmolar. See, normo-osmolar, it is very easy. If it is normo-osmolar hyponatremia, you have to look for either paraproteinemias or hyperlipidemia. If it is hyperosmolar, it is very simple. You need to see whether sugars are high or whether there is mannitol administration happening. So these two are simple. When you have hypoosmolar hyponatremia, that is where the problem is. Then you have to ascertain whether the extracellular fluid is more reduced or it is increased. So when the extracellular fluid is normal, the commonest cause I said is SIADH. But for saying SIADH, we have to rule out hypocortisolism or glucocorticoid deficiency or hypothyroidism, which can also present with hyponatremia, hypoosmolar state with normal extracellular fluid. So you need to rule out glucocorticoid deficiency and thyroid deficiency. And if the extracellular fluid is increased, it's very simple. You have a fluid overload state, which is heart failure, which is a cirrhosis or nephrotic syndrome. So the problem is if the extracellular fluid is decreased, it becomes a little more complicated. So when the extracellular fluid volume is decreased, then you need to do urine sodium. So if the urine sodium is less than 10 millimoles per liter, it means there is a lot of sodium loss due to vomiting or due to the diuretic use. If the urine sodium is more than 20 millimoles, or there is extra renal sodium loss, if the urine sodium is more than 20 millimoles per liter, then there may be underlying hypoaldosteronism because aldosterone retains sodium. So because there is low aldosterone, sodium is not being retained, or there is a renal salt wasting syndrome, or there is salt wasting happening from the kidneys. So this is some of the cause. So when there is reduced ECF, that is when your urine sodium becomes valuable. Then there are remote causes. Why do we do urine osmolality? Because if urine osmolality should be, if it is less than 100 milliosmoles per kg, it means it's a dilute urine. So when there is a dilute urine, look at the specific gravity. If it's less than 1.003, then probably there is underlying neuropsychiatric problem, or there is a primary polydipsia, because kidney is not able to concentrate the urine because the water consumption is so much, with the urine output exceeding 12 liters, the kidney is unable to concentrate the urine. If it is urine osmolality is more than 100 milliosmoles per kg, it means urine is being concentrated. Why is it being concentrated? Because there is increase in the circulating ADH levels, which is retaining all the water, and the urine osmolality is more, and there is more concentrated urine that is coming out. So the treatment of hyponatremia, there are three goals of treating hyponatremia. One, the important goal is to increase sodium. See, for all the listeners, the main sort of a gospel for hyponatremia in most of the causes. So if you look at any cause of hyponatremia due to hypoosmolar state, due to normal extracellular fluid, increased extracellular fluid, or with normal osmolality, the key essence or the key gospel would be to restrict water. So that is the key element that every listener should bear in mind. Don't give unnecessary fluids, because the first step you need to correct hyponatremia is to restrict water restriction and to promote water loss and replenish the sodium or potassium or both with hypertonic saline if needs be. And the third important thing is to correct underlying cause. So the rate of correction, this is a common thing that I would ask all my trainees. Is a very simple thing. So desired change into free water. Free water is 0.6 into body weight in males and 0.4 into body weight into females. And the correction should never exceed more than 8 millimoles per liter per 24 hours because of the risk of causing central pontine myelinolysis, which leads to dysarthria, quadriparesis, and seizures and neurological manifestations. So only symptomatic hyponatremia, the rate of correction should not generally exceed 5 millimoles per liter per 24 hours. And in asymptomatic, it can be much slower. So this is a in gist on the overview of hyponatremia. So with regards to the other modalities like giving Vaptans for hyponatremia, there is a separate talk on Vaptans, the role of Vaptans in hyponatremia. So you can refer to that talk on my website, www.drpradeeprangappa.com, or on the YouTube. So this is an overview as to how we approach a case of hyponatremia. So it is a very simple thing. The osmolality, serum osmolality remains the key. So you have to check the serum osmolality to determine whether it is hypo. Most of the hyponatremias in ICU come under hypoosmolar hyponatremia. And generally it will be with normal extracellular fluid. Most of the times it will be SIADH, or it will be with the increased extracellular. And many a times we see with reduced extracellular fluid, especially in patients who are on diuretic or who have had diarrhea and vomiting. So these are the general causes that we see in ICU. Sometimes we see with normal osmolality, and that we see in paraproteinemias, and especially hypercholesterolemia, we have seen that. So there is this other MCQ question we would ask: causes of hyponatremia with increase in potassium. So there are certain causes like spironolactone, which is a potassium sparing diuretic, causes hyponatremia with increase in the potassium, or diabetic ketoacidosis, you can have low sodium with high potassium, or hypoaldosteronism, or salt wasting nephropathy. So these are some of the causes. So these are all MCQ questions for trainees who are interested, can keep this in mind. So that's about the overview, friends. So you can read to this lecture by visiting my website. So I will do the so this is the first part. The Vaptens is done. So I will do another second part where I'll touch about the underlying pathophysiological detailing about the water balance and how the hyponatremia happens. So I will do it in the second video. So thank you one and all. And I'll end with this beautiful quote. Yeah, thank you.